While she's getting her PIN number put in, let me just go ahead and start with this first paper, which was really interesting to me. I think I've only seen one case of STAT5B deficiency, and so I'm always eager to read more about it. And it's relevant for the case that's coming up because, of course, one of the cardinal features of STAT5B is short stature, and our first case definitely is a case of short stature. And so this represents a wonderful paper from Argentina, and they studied 3 patients long-term. And remember, one of the features of STAT5B in addition to short stature is the decreased regulatory T cells, and that's a pretty consistent feature. Some of the clinical features are more variable, like infections, and they often get a type of lymphocytic interstitial pneumonitis as well as chronic diarrhea. So they look a little bit like IPEX, but they have these other features as well. So Joyce, I think you're on. Do you want to take it away?
Sure. Can everybody hear me now? Hello? Okay, great. Okay, so so to pick up where Kate left off, so one of the other interesting immunologic features in these patients is, as to be expected, severe lymphopenia, as well as decreased FOXP3 Treg cells, and thus decreased mitogen responses. Interestingly, these patients have an increased IgG and IgA level, as well as increased autoantibodies, which goes back to the fact that there's some dysregulation occurring in this immune deficiency. As well as it's been noted that some of these patients also have an increased number of switched memory B cells. So I guess Kate was saying this is a pretty good compilation of clinical immune features in STAT5B deficiency. So this may be a good reference source for you in terms of identifying these patients in the future. So for the next paper I wanted to present was a longitudinal evaluation of immune reconstitution and B cell function after stem cell transplantation for primary immunodeficiency. So this paper compiles some clinical data on 17 different PID patients with about 77% survival. So about 13 of these patients were followed longitudinally over various number of years. They all had varying PIDs, conditioning regimens, and donor types. And in this cohort, most actually didn't have severe late BMT-related complications. And in regards to B cell function, about 9 of these patients were actually off of all immunoglobulin replacement therapy about 2 years after their transplant. In terms of the B cell development that was followed after transplant, most of the patients had normal B cell counts. There was a delayed rise in the total memory B cells, with the switched memory B cells rising earlier than the IgM memory B cells. And of the patients that actually were able to stop their immunoglobulin therapy, many actually were able to mount protective titers when challenged to vaccination. When these cells from these patients were stimulated with a CpG analog, they found variable proliferation responses in immunoglobulin production. It was best in the patients who had received a matched sibling donor transplant. And it seemed that the good antibody function seemed to be correlated with a donor B cell chimerism, as well as using a good myeloablative conditioning regimen. So this study, provides additional data about B cell reconstitution after BMT, which has eluded a lot of us for a long time now. But this, because of the kind of inability to generalize this data, I think it really points to us and tells us that more studies are really needed to understand post-BMT B cell recovery. The next paper I kind of wanted to briefly go over was the late onset disseminated MAC infection, cerebral toxoplasmosis, and salmonella sepsis in a German Caucasian patient with unusual anti-interferon gamma IgG1 autoantibodies. So this is an interesting case report in which they describe a 65-year-old Caucasian woman with disseminated MAI, cerebral toxoplasmosis, and salmonella sepsis. And this is interesting because up to now, majority of the patients who have been noted to have the interferon autoantibodies are generally Asian patients with a specific HLA typing, and those patients are the ones that have the non-tuberculous mycobacterial infections. Now, up to now, there's only been one prior report of a Caucasian patient with interferon gamma autoantibodies. In this case report, they report her laboratory testing in this patient that she had normal lymphocyte levels and immunoglobulin levels were actually normal to somewhat increased, and she did have a negative HIV test. Her peripheral blood mononuclear cells produced almost no interferon gamma, but when they were incubated with normal control serum, they actually produced normal levels. They noticed a very high titers of interferon gamma IgG1 subclass antibodies were detected in this patient by ELISA, and to prove that these other antibodies actually blocked function, the monocytes that are pre-incubated with the patient's serum were stimulated, and they found that the interferon gamma mediated phospho-STAT1 phosphorylation was blocked. Interestingly, this patient's HLA phenotyping was described in one of the affected Asian patients in the original cohort from Taiwan. So this case report really illustrates the role of autoantibodies in causing severe immune deficiencies, something that we considered when you have patients that present with severe MAC infections. And the very last paper I kind of want to review before we move on to the cases is an interesting paper in which they discuss outcomes in 2 Japanese ADA SCID patients that were treated by stem cell gene therapy without cytoreductive conditioning. As you know, up to now, recent stem cell gene therapy protocols for ADA SCID include no enzyme replacement therapy, and most of these patients do receive cytoreductive conditioning, kind of open up their bone marrow space. But it's unclear whether the cytoreductive conditioning does it really help, or is it not really effective. So what they did in these 2 ADA SCID patients is they actually transplanted them without conditioning. So one was 4.5 years old, and the other was 13 years. Neither of them received enzyme replacement therapy prior to harvesting the bone marrow. And the one patient, the older one, had previously received some peripheral T-cell gene therapy with some different vectors. In terms of their follow-up, so one patient's absolute lymphocyte count did increase, but eventually did decrease. And in the other patient, the absolute lymphocyte count, unfortunately stayed pretty subnormal. No naive T cells or TREX were noted in either patient, and unfortunately, in both patients, they had pre-poor B and NK cell recovery. Both patients did have initial improvement in their ADA activity, but however, there was an eventual decrease that was noted. So the authors suspect that there's probably some limited engraftment of the progenitor cells, probably due to the lack of the cytoreductive conditioning. However, so far, fortunately for both patients, there was no leukemic transformation so far. But unfortunately, due to the decrease in the AD activity, one patient did have to go back on the enzyme replacement therapy, and they suspect that the other one likely will have to go back as well too. So based on these sort of not very great results, the authors concluded that the cytoreductive conditioning that's done prior to transplant is probably beneficial to engraftment and stem cell gene therapy. So that concludes our literature review. Sorry about the audio problems.
So, Joyce, that was really wonderful. I think that gene therapy paper is really interesting because, you know, it becomes a much more difficult equation to sell gene therapy to patients if they're going to have to undergo some kind of chemotherapy or conditioning, just like for a transplant. So I find that sort of a worrisome evolution in the trajectory of gene therapy, which has already been fraught with so many challenges along the way. Do other people see it the same way? Joyce, do you see this as a big problem? While you're talking, I'm just going to go ahead and put up a presentation.
Yeah, I mean, I think it's like what we saw in our annual meeting. I think it's funny because a lot of us we think we're just immune deficiency doctors. I think the stem cell gene therapy, the transplant, we're all sort of becoming transplant doctors, I think, because I think that's going to be the ultimate treatment for a lot of these patients with immune deficiency. So it's things to consider in terms of how we treat these patients and how we manage them, I think.
Thank you very much. Our first case, as I mentioned, is a really fascinating case where we're all going to have a chance to put on our thinking hats. It is presented as a mystery case, and it will be presented by Bruna Aquilante and Diogo Soares. Please take it away.
Hi, good evening. I'm Bruna, a first-year fellow in allergy and immunology. Thank you for the privilege to share with you the discussion about this case recently referred to our Children's Hospital in São Paulo with the diagnosis of CVID for assessment of splenectomy risks to treat a refractory autoimmune hemolytic anemia. As it's the initial evaluation, we will emphasize the clinical data. The patient is Francisco, a 14-year-old boy from a small city in the state of Piauí, northeast of Brazil, where consanguineous marriages are common, as in the case of his family. The healthy parents are first cousins and had a first male child who died at 14 years of age due to lung infection, and also presented chronic diarrhea, failure to thrive, and anemia since 5 months old. He was splenectomized at 4, and the second child is a healthy female teenager, and the third is our patient. As you can also see in the pedigree, the grandfathers are also first cousins. Talking about his clinical history, pregnancy and delivery without complications, with normal weight and length. At 10 months of age, he presented chronic diarrhea, anemia, and failure to thrive, and started presenting episodes of XHIGM. At 4-year-old, was diagnosed of autoimmune hemolytic anemia and received oral prednisone for 7 years. Around 11-year-old, he started presenting recurrent bacterial pneumonias, hypogammaglobulinemia with low IgG, IgM, and IgA levels, and started IVIG monthly. No other infections have been reported. At age 12, due to the short stature, he received G8 treatment for 8 months without response. He had recently presented numerous admissions and blood transfusions due to autoimmune hemolytic anemia, and he was referred to our service in order to access the splenectomy risks. Regarding physical examination, he presents severe proportional short stature with a minus 6.5 Z-score, without facial dysmorphism, without signs of puberty, normal neurologic development, sparse XHIGM lesions, hepatosplenomegaly, and absence of lymphadenopathy. Blood cell counts revealed anemia with normal numbers of leukocytes, absence of eosinophils, normal lymphocytes and platelets, high leukocytes, positive direct cum test. His hormonal profile revealed normal level of G8 and several occasions, IGF-1 normal or slightly decreased, normal prolactin, and normal thyroid hormones. Regarding images, the abdominal ultrasound demonstrated the hepatosplenomegaly. Skeletal X-ray showed a hand bone age of only 9 years and the osteopenia. And the chest CT revealed bronchiectasis in both lung bases. In immunological evaluation, he presented low IgG, even under IVIG, low IgM, undetectable IgA and IgE. Immunophenotyping showed normal number of CD4 and CD8 lymphocytes, but with inversion of CD4-CD8 ratio, low numbers of memory T cells, B. lymphocytopenia, and normal T regs analyzed only once.
Bruna, can I stop you there? So I just put up a poll for people to vote in about STAT5B deficiency because of this child's autoimmune phenotype and short stature. So you should see, do you see the poll? Or did it disappear?
I see the result. Oh, there it goes.
So you should be able to vote. As I said, I had trouble with this last time, so maybe it's just not in the Maybe it's not in the cards tonight. Oh, no, now I see.
Oh, here it goes. Hey, it's coming.
Okay, so let's just give it a minute and see what people, At least for me it disappeared. So let me just tell you the pearl about it in case you didn't get to vote. So I was asking about the classic dysmorphic feature associated with STAT5B. It's not always very dramatic, but it's a saddle nose is the most common dysmorphic feature. And Bruna showed beautiful pictures of her patient with a lovely nose, certainly no hint of a saddle nose at that point. So I'm going to close this screen and let Bruna continue.
Good evening, everyone. My name is Joyce. Sorry?
Hi, Diago, are you there?
Hi, Dr. Kate. I'm here. Good evening, everyone. Well, my name is Diogo Soares, and I am a third-year fellow in clinical genetics. Well, I will discuss with you about the diagnostic approach raised by our team in this case. For this, we consider the consanguinity and the fact that the patient had a brother with a similar clinical picture that suggests a disorder inherited in an autosomal recessive fashion. The patient has a diagnosis of CVID, but considering the patient's proportionate short stature, the absence of signs of puberty, the high-pitched voice, and the presence of autoimmunity, we think there is a possibility of STAT5B deficiency. However, an analysis of the patient's hormonal profile made this hypothesis less likely, as previously presented by Joyce. We also consider the possibility that the patient could have homozygous mutations in LRBA gene that causes a syndrome characterized by early onset of recurrent infections, particularly of respiratory tract, and also develop variable autoimmune disorders, including autoimmune hemolytic anemia, and the immunologic findings are also variable and may include decreased B cells, hypogammaglobulinemia, deficiency of Treg cells, and a high frequency of memory T cells with increased autoantibody production. However, the previously mentioned diagnosis does not usually present short stature. Moreover, considering the features of autoimmunity, hypogammaglobulinemia, and T&D lymphopenia, we need to think in rag gene defects and other defects leading to combined immunodeficiencies. However, once again, short stature and pubertal delay are not usual in this case. Another disease that we...
Diago, can I ask a question?
Yes, of course.
There are several people in the chat box that are asking about whether the short stature could be due to his steroid use. In your opinion, is that an explanation for how short he was?
Yes, we consider a lot the environmental and the chronic use of corticosteroids since the first years of the life of this patient, and even we discussed with the endocrinology team of our hospital about this hypothesis.
So in your opinion, his shortness is because it's not due to the steroid use, in your opinion?
Actually, we have some doubts about this because we think in two possibilities. One of them is that it's a genetic defect leading to an isolated short stature, because we need to consider that the parents of the patient also present a short stature. And the second possibility for Francisco's short stature is that maybe a consequence of familial short stature plus long-term use of corticosteroid and plus chronic disease since the first years of life with several infections, mainly pneumonia, but he also presented chronic diarrhea. So we need, this is a very complex to determine what's the mechanism that leads to this short stature.
I see. There were a couple of other comments in the chat box that you might have missed because you were busy. Two people very alertly recognized that there was a gap between the CD4 plus CD8 and the total T cells, suggesting that there might be double negative T cells. And I want to acknowledge John Ziegler, who's joining us from Australia, I believe, so quite a long distance. So do you have a comment about the missing T cells?
We analyze the double negative T cells and compare with the control of the day, the value was normal.
Okay. And Gabriella, please use the send to everyone, but she's asking about lymphocyte proliferation. And I presume that has to do with thinking about the IL-2 receptor.
Well, unfortunately, we don't have just a comment. Unfortunately, we don't have the chance of perform evaluation of lymphoproliferation of this patient. So we can't contribute with this information.
Okay. So you have a really wonderful set of hypotheses about what this could be, not, as you point out, not all associated with short stature. I just wonder if folks in the audience who have been also proposing some interesting ideas have thought about other immune deficiencies, particularly associated with autoimmune disease, where we see short stature. There's a bit more that we could probably put our heads together and come up with for that particular phenotype. Anyone want to propose something? So Roni Greenberg is suggesting ligase 4. He also put XLP, which is a little harder to factor in with the short stature. So ligase 4 and Cernunos, because I think of them as sort of together. Other people, do you have some other thoughts? I know that you do. Well, let's not leave out a classic one. Cartilage hair hypoplasia. You always need to think about that. I did look long and hard at the picture of the patient, looking for short limbs. It's a little hard to tell. Oh, Luis Ignacio Gonzalez proposed cartilage hair hypoplasia. We also have the very rare Shim Immuno Osseous Dysplasia. Is everyone familiar with that? It has one particular aspect that is pretty universal that's not seen in this patient. Does everyone remember what it is? It's an organ we don't usually think about. Nephrosis, yes, but John, you're a grown-up. I know you know this. Yes, so Shimke's immuno-osseous dysplasia also can be associated with short limbs, has a very characteristic bone X-ray, but always develops, by this age anyway, not necessarily in infancy, but by this age would always have a type of nephrotic syndrome, absolutely. So those are just a few other things to add to your list when you're trying to think about short stature and immune deficiency. Could also think about Kabuki syndrome and CHARGE. They are also associated with short stature, but those are much more associated with developmental delay and some other dysmorphic features. We have, oh my goodness, we have a couple of dark horses here. We have PGM3 deficiency from Eric Allensbach. Yes, is associated with short stature. I'm less familiar with the autoimmune phenotype, though. And then we have a great suggestion of Shwachman-Diamond syndrome, although I think this immune deficiency, just the laboratory studies would be a little bit atypical for that without a bit more neutropenia. So some great suggestions from everyone. Diago, do you want to tell us where this case is going?
Sorry?
Do you want to tell us where this case is going? What do you have planned?
Yes. Well, as I told to you, we think in several hypothesis for this case. The other possibility that we consider was a gain of function germline STAT3 mutation that was recently described due to short stature, early onset autoimmunity, including cytopenias, hypogammaglobulinemia, delayed puberty, and recurrent infection. But on the other hand, this effect is inherited in an autosomal dominant fashion, with most cases result from a de novo mutation. And the patient parents are healthy and have a previous affected child. So actually, in conclusion, considering the features of short stature and pubertal delay, uh, we intend to make in the first moment a sleep array to exclude chromosomal abnormalities that may lead to this phenotype. And if this is normal, we intend to perform a whole exome sequence to elucidate the diagnosis. But regarding the management of this patient, first of all, the patient present hypogammaglobulinemia despite the use of IVIG, and he has had recurrent respiratory infection, and the chest CT showed bronchiectasis in both lungs. So we believe that the dose of IVIG should be increased, aiming at a better control. Regarding the refractory autoimmune hemolytic anemia, the key point of the discussion is whether splenectomy is indicated for this patient. And we really would like to hear from you about this.
Well, this would be a great opportunity for that poll function, wouldn't it? So, I would be tempted to start with rituximab because you don't burn any bridges by doing that. I don't know if that's a phrase that you know, but it means you haven't crossed anything off your list that you could use later on. Whereas if you do a splenectomy, then obviously you can't go back and undo it. So that would be my temptation, but the spleen is certainly very big. And do you think it's full of granulomas, for example? Is it very hard when you palpate it? Does the
patient
feel
don't
very
present
hard to touch it?
the patient don't present granulomas in our evaluation.
Okay. So, he might be better off without his spleen, but I guess I would probably start with rituximab. But let's hear from other people. I also want to highlight, it's going to fall off the chat box in a minute, but Luis Gonzalez Granado mentioned PI3KD, which is a great suggestion because of the bronchiectasis. We sort of went past that quickly, but in the CT scans, or I think you had a CT scan, there was pretty significant bronchiectasis. And do you think that that is completely accountable by his recurrent infections, or do you think that the bronchiectasis is more than you would expect from the infections?
Actually, we have doubts about this. We really don't know.
Okay. So it did just fall off the chat box, but I thought that was a really good suggestion. It doesn't account for everything, but the autoimmunity and the hypogam and the low B cells would certainly be consistent. We do have some other people chiming in with treatment. We have a suggestion of rapamycin. Howard Letterman reminds us that the low immunoglobulin might be amenable to treating with sub-Q. You might be able to get the level up a little better. We have, from Michael Keller, we have mycophenolate mofetil. I think of rapamycin and mycophenolate mofetil as being pretty comparable in terms of the level of immune suppression. So I think both are nice suggestions. Abatacept. So we're definitely seeing lots of people who are voting for immune suppressive treatment. Does no one want to stand
it's very
up
interesting.
for the
it's very interesting because in our discussion we don't consider this possibility. Actually, we just thinking it might be possible to try, of course, a less aggressive option, namely the use of rituximab. But this is a very good suggestions.
I think they are. I don't know how available all of these medications are. Rituximab is, I think it has a lot of pros in this particular circumstance. Autoimmune cytopenias are often very, very sensitive to rituximab. But of course not everyone responds. Any other suggestions for treatment? Diago, I noticed that you raised the question of treating his short stature. I'm not actually familiar with IGF-1 therapy. Do you want to say a few words about that?
Actually, our group of endocrinologists didn't have any experience to use this drug in our center. We just raised this possibility, but we don't have any experience with this treatment in our hospital.
Let me, people, please feel free to speak up using the chat box. Joyce, do you have any experience with IGF-1? It's just, it's never entered into my domain, so I'm not familiar with it at all.
No, it's not, I'm not familiar with it at all either. I haven't heard of. I'm not sure in terms of talking to endocrinologists with regards to short stature as to whether they've used that as a therapy. No, not that I'm aware of either.
Okay. Diago, do you have any other questions for us?
No, Dr. Kate. I would like to invite Professor Magda Carneiro Sampaio to talk.
By all means.
Okay. Hello. How are you?
Hi, Magda. Can you speak up a little bit?
Yes. I would like to thank you very much, you all, for the helpful suggestions. And I hope to have genetic data in 2 or 3 months to show you and to try to propose better treatment for Francisco, our patient. Thank you. Thank you very much.
Oh, thank you for this interesting case. And Magda, Bruna, and Diago, I hope you will keep us posted on how this turns out. Often hearing the answer is really helpful, helpful for all of us. So I hope you'll let us know how it turns out. And with that, I'm going to change over to our second case of the night. Sorry. Here we go. So this again is, Brian is going to present this as a mystery case, and boy, it knocked my socks off. It was really a surprise to me as well. So be prepared to get your chat box fingers ready so that you can start voting, because it does have quite a surprising ending. So Brian, why don't you get started?
All right. Yeah, thank you very much. Just wanted to say thank you to everybody for allowing me to present this really awesome case that I've been following since the start of my fellowship. I'm a third-year allergy and immunology fellow at the Medical College of Wisconsin. I'm just going to talk to you about the 6-year-old who's had progressive dyspnea, clubbing, and pulmonary fibrosis. She first presented to the hospital with a 9-month history of progressive dyspnea, cough, fatigue, and a striking 15-pound weight loss. She was a skinny girl to start with and became even more so throughout time. She had been monitored by her pediatrician throughout this 9 months, who had diagnosed her with mild persistent asthma and started her on an inhaled corticosteroid. Otherwise, her past medical history was pretty negative, including severe or invasive infection. interestingly, on social history, the parents were noted to have immigrated to the United States from Mexico. However, they were from different small towns. And also there was a somewhat of a fairly not well taken care of parakeets at Dad's house that was disclosed during the immunology consult. On physical exam, when she came into the hospital, she was ill-appearing, dyspneic, hypoxic, as well as significantly tachycardic. Her interesting features on exam was that she had significant, severely diminished breath sounds bilaterally, as well as poor aeration. And on extremity exam, she was noted to have 4+ clubbing of her fingers and toes, and her liver was palpated about 1.5 centimeters below the right causal margin. I kind of figured at this point maybe I would stop and see what people think, or what other diagnostic workup would you start with?
Well, Brian, frankly, I'm surprised that immunology was called. I think at my institution it would have, I think it would have taken a lot longer to call an immunologist.
Yeah, and we got involved a little bit after some of the diagnostic workup that I'll show you happened. But we did get involved pretty early on.
So folks in the chat room, be sure that you use the send to everyone feature. Otherwise, a few people will see it, but not everyone. So try to use the send to everyone in that little bar where you're typing. And Brian,
so
people are
like
a chest X-ray and a CT scan. Those seem quite reasonable to me. But I wonder if folks want a likelihood of hypersensitivity pneumonitis given the parakeet exposure. I don't really think about those diseases very often. Does that seem very likely here? So we have a couple more suggestions. Cystic fibrosis. I didn't hear you comment on whether she had CFTR gene testing or a sweat chloride.
She did. She ultimately did have that, and that was all normal. So several people have asked for imaging right off the bat, and that was the first thing that she had done. And so she had a chest X-ray in the emergency department that showed extreme interstitial lung disease, hilar adenopathy, and enlarged pulmonary arteries. And at that point, she was admitted to the hospital and sent to the CT scanner. And here is what we found. So you can see that there's severe interstitial pneumonia with honeycomb lung. They had described a mosaic airspace disease throughout her lungs with significant mediastinal and hilar adenopathy. And just pretty bad throughout her entire lungs, as you can see. I saw somebody ask for PFPs. I think that's a great idea as well. And I only just show you some of the main things, but she did have full pulmonary function testing, and that showed pretty significant restricted disease without reversibility. So given the significance and the severity of her disease, that she was taken for bronchoalveolar lavage and biopsy of her lung. And here is what her biopsy looked like. It showed non-uniform diffuse granulomatous and interstitial inflammatory process with really no normal appearing lung in any of the biopsy specimens. Someone asked if she had dextrocardia. I see she did not have dextrocardia. Additionally, there was non-uniform perivascular, peribronchial, and alveolar fibrosis, and these kind of interstitial non-caseating granulomas throughout. Somebody asked for cultures in the biopsy. This poor girl had more infectious disease workup than anybody I've ever taken care of. And every infectious disease was negative. So she did not have renal disease.
Again, for my
either.
education, would this be consistent with hypersensitivity pneumonitis? This seems quite extensive. Actually, as you point out, there's hardly any normal lungs. Could you see this much granulomatous inflammatory reaction from hypersensitivity pneumonitis?
So the pathologists were quite confident at this point that the diagnosis was hypersensitivity pneumonitis, and said that it is common to see significant granuloma. However, they usually are more peribronchial than they are interstitial granuloma. So I think it was suggestive but not classic. So because of this kind of significant bird exposure, as you were bringing up, Kate, we read a hypersensitivity pneumonitis panel was sent off, and the precipitants to specifically parakeet were positive. Additionally, we did obtain poop from the house and did our own precipitant testing, which was positive as well. And there's a question that we did we do a cell count on the BAL, and it was a CD4 predominant cell count. So at this point, she was diagnosed with hypersensitivity pneumonitis. She was started on systemic steroids with questionable improvement, and ultimately allergy and immunology was consulted. So
you
kind
know,
of my next.
Presenting this case, you know that there's a reason he's presenting it. So let's have a group think about what this might be. And no, you don't get any more data. Those of you that are asking for antibodies and LFTs, you don't get any more data. You just have to vote now on what you think this could conceivably be. If you are Brian walking into this room, hearing this story, thinking about immune deficiencies, where do you start? Well, we have one brave soul. A couple brave souls. Think about what Brian has told you. Think about the most significant elements of this case. Oh, people are really sort of definitely buffaloed by this case. So, Brian, I see GATA2 up there. GATA2 certainly has a significant pulmonary component, but it would not look like this. Would you like to contrast the two types of pulmonary disease?
I think it's generally, in this, it's more of an interstitial, kind of like pneumonia picture with the granulomatous inflammation. I think that's as best I would be able to tell you at this point.
So GATA2 deficiency is associated with pulmonary alveolar proteinosis in really just enormous quantities, really only seen in adults. You don't get that aspect of it much in childhood, but that's the pulmonary disease in GATA2 deficiency. Joel Gallagher had also suggested surfactant deficiency, but this is much, as you point out, Brian, this is much more of an interstitial process. We've got a DNA repair defect. I think people thinking about interstitial fibrosis that you see with DNA repair defects. Also, don't forget, very common with the telomerase defects, so the dyskeratosis congenita, that whole category, definitely associated with interstitial fibrosis. Not usually so much granuloma, but certainly compatible with the fibrotic aspect of this case. We've got a couple votes for common variable, and certainly we're used to thinking about granulomas in common variable.
Mm-hmm. Absolutely. So,
Brian, what was going through your head at this moment?
So we were we were thinking about many of the different things that people have talked about so far, especially CVID and other non-immunologic causes such as sarcoidosis and other infectious type processes. With the thinking about severe inflammation, we thought about other things including CVID or CGD and other type of things. So we sent out a pretty broad immunologic workup. Do you want me to continue with that?
Yep, go ahead.
Okay. So our immunoglobulin panel revealed some hypergammaglobulinemia with an elevated IgG, normal complement studies, and a pretty normal lymphocyte immunophenotyping, even on high-dose steroids. We did send off a DHR, which was abnormal, and I will show that to you in the next slide. So on the left side of the slide, you can see our patient, and on the right side is the control. You can see that our patient had a very small response in the red to PMA, whereas the control response was significant respiratory burst. And we didn't believe it at the time. We were very surprised that she had an abnormal DHR, so we repeated it to make sure that we thought that it was what it was, and her DHR came back the exact same the second time. So we then sent genetic testing, and she was found to have a mutation in the NCF1 gene or the P47 Fox gene, and was diagnosed with autosomal recessive chronic granulomatous disease. She was started on prophylaxis with Bactrim and itraconazole. And these are some of the questions that we had when all of this came back. We were very surprised by the diagnosis, given the lack of an infection history in a 6-year-old girl. How much experience do people have with interferon gamma? Do they use it? And then in this case, given how severe her lung disease is and likely continuing to be progressive, would you perform a stem cell transplant?
So let's just go back to the laboratory. I just want to make a tiny point about that. So way back in the olden days, even before I was an immunologist, one of the key diagnostic features of CGD was hypergammaglobulinemia, so a high IgG level. And of course, it makes sense given their recurrent infections. But it was actually at one point part of the diagnostic criteria for chronic granulomatous disease back at a time when we did not have specific diagnostic testing. So I just wanted to highlight that because it is, for the kids that are diagnosed late after they've had a number of infections, it is fairly characteristic, certainly not diagnostic, but I did just want to highlight that. And then, although this girl was on high-dose steroids, another very underappreciated aspect of CGD is that typically the T cells will be low, not like a combined immune deficiency, but they're certainly not normal T cell counts. And then remember, CGD patients often will have diminished switched memory B cells. So this is clearly a workup that was designed to capture common variable and any serious T cell defects. But it does highlight some of the features that I think can be confusing sometimes in CGD because we don't think of CGD as having adaptive immune abnormalities, but in fact they do. So I just wanted to highlight that before we move on. Brian has some very important questions, and I think we should try and deal with those. So I'm gathering that people were surprised by the diagnosis. I was certainly surprised. Were other people surprised? So there's a little confusion about whether this is CGD plus hypersensitivity pneumonitis or whether this is just lung disease in CGD. What do you think about that, Brian?
Yeah, we've had that conversation over and over and over again. And we had several different pathologists throughout the country review her pathology, and they felt, given the fact that these were more tight granulomas, along with the fact that they were not peribronchial, that this was more consistent with a CGD type picture than hypersensitivity pneumonitis.
And I just want to highlight that Atusa Kurash knew all along that this was CGD. Very impressive. So what about gamma interferon? Not so widely used in the United States anymore, but I wonder how much people are using it in CGD in other countries. It certainly is used in the U.S. I don't mean to make it sound like it's not, but it's probably not as commonly used as it once was. So yeah, it seems like a lot of people use it.
Yeah.
And then probably the most important question, what about stem cell transplantation, specifically in this patient who has sort of a premorbid condition of bad lung disease? What do you think the pros and cons of transplant are in this kiddo? So Annalisa has just transplanted a CGD patient. There's actually a paper about transplantation for interstitial lung disease. But these are lungs that are pretty bad, and her PFTs are not so good looking. So would people be reluctant to transplant her, or all the more reason to transplant her? So Joyce, what would you do? Do you think that this would be a transplant candidate at your center?
I think having the pulmonary disease, I think personally having the pulmonary disease would almost make it more of a reason to try to transplant her to fix it. Although I can see why there would be concerns with her having underlying pulmonary disease in terms of how she would tolerate the transplantation. But I think the way to fix it would be with a transplant.
And we're getting some more comments coming in, generally quite positive.
Yeah, and I think Dr. Keller's question was one we had as well. She was admitted on several different occasions for respiratory type complaints, and we ultimately did admit her once for high dose steroid infusions, doing 1 gram of steroids on three straight days to see if we could really get her lung disease better, and she improved somewhat, but not as much as we had hoped.
Yeah, you'd think you could, you'd think you could melt those granulomas with the steroid, but probably not do much about the fibrosis. I noticed that her FEV1 is 24%. That's pretty close to our threshold for considering someone a transplant candidate. But I think, like most of the people that are commenting, I think we would do a transplant. You do typically regain a fair bit of function, even though you'd guess that the fibrosis is not reversible. Just looking at the patients that have been transplanted, they do regain a surprising amount of function. So is that what do you think you're going to do?
Yeah, that's exactly what we decided to do. We felt like doing the transplant was going to be more benefit and potentially life-saving for her. So she had a haploidentical transplant from mom, and is now today day plus 525 days from her transplant, and is doing relatively well. She had a repeat DHR that was markedly improved, and her respiratory status as well has significantly improved, including her clubbing. And we got a recent CT scan, and you can see significant improvement in her CT scan findings, including the kind of septal thickening, the lung volumes have improved, and her interstitial disease has improved a lot. So we were we've been very pleased with how she's progressed. So this is just kind of a summary of what we had. That's about it, I think.
Very nice. We're going to stop. We're out of time, but I'm just putting into the public notes, which will get emailed to everyone, 2 papers specifically on P47 CGD. And the reason I'm doing that is that it actually behaves subtly differently from classic CGD, even considering that it's autosomal recessive. There's one particular infection that occurs almost exclusively in P47 CGD called Trichosporin incan. And there's it's also the group of CGD patients that are at highest risk for diabetes. So I'm just going to before we sign off, type that into the public notes, which will go to all of you. Sorry, I can't really talk and type at the same time. Many apologies. So that's done. And with that, I would like to thank all of the presenters. Brian, Bruna, and Diago, thank you so much. Really excellent, thought-provoking cases. I really appreciate the time and effort, and especially to our Brazilian colleagues. I hear that it is a holiday, so I especially thank you for coming in on a holiday so that you could present to us. Very much appreciated. Really excellent cases. Thank you so, so much.